Bismillahirrahmanirrahim. Good morning, everyone. Today, the topic of our lecture is the thyrotoxicosis. And what is thyrotoxicosis? Actually, it is the hyperthyroidism. What is the hyperthyroidism? The symptom hyperthyroidism means the increased level of thyroid hormones in the blood circulation. The increased secretion of the thyroid hormones T3 and T4, and there is the increased secretion present in the blood stream. And this is the hyperthyroidism and giving the signs and symptoms due to a raised level of circulating thyroid hormones. Basically, this is the hyperthyroidism is that increased level of thyroid hormones, increased secretion of thyroid hormones, and giving the symptoms due to raised level of thyroid hormones. But all those manifestations which are due to the increased level of thyroid hormones is not due to hyperthyroidism. But there are other manifestations which are more toxic. The signs and symptoms of toxicity are there. When the patients with a hyperthyroidism having the symptoms but showing the signs and symptoms of toxicity, they are the toxic symptoms, then we call it a thyrotoxicosis. Basically, thyrotoxicosis is a type of hyperthyroidism. Hyperthyroidism means the raised secretions, increased secretion of the thyroid hormones and increased level of thyroid hormones in the circulation. But thyrotoxicosis is that type of hyperthyroidism in which there is the toxicity, signs and symptoms of toxicity are present. The toxic features are present. Then we call it a thyrotoxicosis. Later on in the later discussion, we will discuss those symptoms and signs of the toxicity. So there are certain types of thyrotoxicosis which are clinical types. One is the Graves' disease. Graves' disease is usually characterized by a diffuse toxic goiter. Graves' disease is an autoimmune disease in which there is thyrotoxicosis. It's a type of thyrotoxicosis, Graves' disease. It is an autoimmune disease and there is a toxic goiter. Goiter is diffusely enlarged. Diffusely means whole of the thyroid gland is enlarged. General enlargement of the thyroid gland, and that is giving the signs and symptoms of toxicity, so we call it a toxic goiter. But it is diffuse, generalized. Whole of the thyroid gland is enlarged. There is a goiter, generalized goiter. Okay, other is the toxic nodular goiter. Basically, the goiter is present, but that goiter is multinodular. Multiple nodules are present, and those all nodules are toxic. There is a multinodular goiter, all the nodules all over the thyroid gland, the nodules are present, these are toxic. Means they are hyperactive, secreting the thyroid hormones in increased level. More thyroid hormones are secreted by these nodules, and whole of the gland has multiple nodules, and all of the nodules are toxic. Means all of the nodules are secreting the increased secretion of the thyroid hormones. So we call it a toxic nodular goiter. While in Graves' disease, the whole of the gland is generalized involved, that is diffusely enlarged, and whole of the gland is toxic. Third type is toxic nodular, means the only a single nodule is present in the thyroid gland, that is toxic, while rest of the thyroid gland is not toxic. Means only single solitary nodule is there, which is toxic, which is hyperactive, which is secreting the high level of the thyroid hormones, while the rest of the thyroid gland is normally functioning. Fourth type is a hyperthyroidism due to any other causes. Now, what is diffuse toxic goiter? Diffuse toxic goiter is present, we call it a Graves' disease as well. It is an autoimmune disease, and there is a diffuse vascular goiter, means whole of the goiter is enlarged, appearing at the same time as the hyperthyroidism, means goiter is present, hyperthyroidism simultaneously occurs. Means occurrence of the goiter along with the hyperthyroidism at the same time. The goiter is vascular, diffuse, generalized enlargement, whole of the gland is enlarged, it is vascularity is increased, and this diffuse goiter is present at the same time as the hyperthyroidism. Hyperthyroidism present, goiter is present, both are present at the same time. It is more common in the younger women, frequently associated with the eye signs. Eye signs are more prominent, frequent signs of the diffuse toxic goiter, Graves' disease. What are those eye signs? One is the exophthalmos. Main is the exophthalmos, protein of the eyeballs. Protein of the eyeballs is called the exophthalmos. Other is the lid retraction, lid leg, and then there is a chemosis and conjunctival inflammation, and other signs. There's a diplopia, blurred vision. Means other signs are also there. So these are the eye signs are manifestations of the diffuse toxic goiter or Graves' disease. While so it is also called the primary thyrotoxicosis. The thyrotoxicosis due to Graves' disease or diffuse toxic goiter, which is more common in the younger women and associated with eye signs, it is called as the primary thyrotoxicosis. Whole of the functioning thyroid tissue is involved, means whole, complete. As I told you, the generalized enlargement of thyroid gland is there, diffusely whole of the gland is enlarged, and whole of the gland is secreting the increased level of the thyroid hormones. And here is the hypertrophy and hyperplasia due to abnormal thyroid stimulating antibodies. There are the thyroid stimulating antibodies. These are the autoantibodies. These are the autoantibodies. Thyroid stimulating antibodies. These are the autoantibodies. And because I have told you before that diffuse toxic goiter Graves' disease is autoimmune disease. It is caused by the abnormal thyroid stimulating antibodies. That thyroid antibodies, autoantibodies, will cause the hypertrophy and hyperplasia of whole of the thyroid gland. So whole of the thyroid gland is enlarged, and whole of the thyroid gland is enlarged. There is a toxic goiter, and that is producing the increased quantities of the thyroid hormones. This is the toxic nodular multinodular goiter. A simple nodular goiter is present for a long time before the hyperthyroidism. What was happening in the Graves' disease? Signs and symptoms of hyperthyroidism appears at the same time when the thyroid goiter appears. Both occur simultaneously at the same time. In this case, the multinodular goiter is present for a long time. Means some patient give you the history that I have this multinodular goiter since 2 years, 3 years. But before 2 and 3 years, the multinodular goiter appeared, but there was no signs and symptoms of hyperthyroidism. Means thyroid gland was normally functioning. That was a euthyroid. When thyroid, this goiter, multinodular goiter, the thyroid was secreting the normal quantities of thyroid hormones. But a multinodular goiter was present. Since last 2 3 years, patient has only multinodular goiter. But that goiter is normally functioning, euthyroid. Thyroid hormone levels are secreted in normal quantities. After 2 to 3 years, suddenly the secretion of the thyroid hormones is increased by this multinodular goiter. Okay, so when the secretions are increased, then we label it as a hyperthyroidism. Means that before 2 to 3 years before, that goiter was a simple goiter, simple multinodular goiter. After 2 to 3 years, that is becomes overactive and causes the increased secretions of the thyroid hormones. So then it is developed a hyperthyroidism. Means the initially the multinodular goiter is present. That is simple goiter, euthyroid, normally functioning thyroid gland, no hyperthyroidism. But after 2 to 3 years, that multinodular goiter is becomes toxic, hyperactive, secreting the more quantities of the thyroid hormones. That means the hyperthyroidism has started. Then we call it a toxic nodular goiter. Do you follow my point? While in case of Graves' disease or diffuse thyroid goiter, what was there? The enlargement of the thyroid gland, and simultaneously at the same time hyperthyroidism appears. Means the toxicity, signs and symptoms of the toxicity occurs. Means the thyroid hormone levels are secreted in a large quantities at the same time. But here the hyperthyroidism is developed later. And in which age group this multinodular toxic nodular goiter is present? It is usually found in the middle-aged or elderly people. And the eye signs are very rare here. These are more common in primary thyrotoxicosis or Graves' disease, but in multinodular goiter, toxic nodular goiter, eye signs are very rare. What are eye signs? The exophthalmos, protein of the eyeballs, the liddle leg, liddle retraction, the chemosis, the conjunctival inflammation, the other signs of the eye signs. Okay, so this is also called the secondary thyrotoxicosis. In many cases of toxic nodular goiter, nodules are inactive, but internodular thyroid tissues is overactive. In some toxic nodular goiters, one or more nodules are overactive in hyperthyroidism due to autoimmune thyroid tissue. Toxic nodule. This is the third form in which only a single nodule is present in the thyroid gland, while the rest of the thyroid gland is normal. Means in rest of the thyroid glands, the thyroid, there are no nodules. Only a solitary single nodule is present in whole of the thyroid gland. And that is a toxic. That is hyperactive. That is secreting the increased concentrations of the thyroid hormones, while rest of the thyroid gland is normal. That is not secreting the increased levels, but that is secreting the normal quantities of the thyroid hormones. And one single nodule is toxic, that is producing the increased level of the thyroid hormones. So this is a solitary overactive nodule, maybe a part of generalized nodularity or a true toxic proteinema. Means maybe the whole of the gland is enlarged, whole of the thyroid gland is enlarged, but one nodule is present in whole of the thyroid gland that is toxic. That is secreting the increased concentrations of the thyroid hormones. Or sometimes a toxic adenoma is present. A single nodule is there, that is we call it adenoma, that is called toxic adenoma, that is secreting the increased concentrations of the thyroid hormones. It is an autonomous. It is self-controlling, autonomous, and hypertrophy and hyperplasia are not due to the thyroid stimulating antibodies. Means it is not autoimmune. It is not an autoimmune, it is an autonomous. Here the histological picture, okay, what changes occurs when there is a multinodular goiter. Acne, flattened cuboidal epithelium and filled with homogeneous colloid. Hyperthyroidism is hyperplasia of acne lined by high columnar epithelium. Many of them are empty and others contain the vacuolated colloid. Now, what are the clinical features of this thyrotoxicosis? The symptoms, here are the symptoms, here are the signs. The symptoms are the tiredness, emotional, the patient becomes more emotional. Heat intolerance means heat cannot be afforded by the patients, means he feels more heat. So heat intolerance, weight loss is there, and excessive appetite. Patient has the more appetite because thyroid hormone levels are the metabolic hormones. So when there is the increased secretion of thyroid hormones, metabolic BMR is raised. So patient feels more appetite. But in spite of good appetite, patient has the loss of weight. And these are the metabolic hormones stimulating the sympathetic system. So because of the stimulation of the sympathetic system by the thyroid hormones, there is the palpitation and signs of tachycardia. Because of this sympathetic stimulation, there is the hot moist palms. There the palms becomes always moist. There is the exophthalmos, protein of the eyeballs, little leg and little retraction, eye signs, which are the features of primary thyrotoxicosis. Patient becomes agitated, excited and agitated. And thyroid goiter may be present, and on auscultation, bruit can be heard. These are the symptoms. 8 times, the as the thyroid goiter is more common in the females, so thyrotoxicosis also occurs more commonly in females. It is 8 times commoner in females. It may occur at any age. Loss of weight is there in spite of a good appetite. Patient has a very good appetite, Because of the metabolic hormones are increased in concentration, BMR is raised, so appetite is good, but there's a loss of weight. Preference for cold. Patient prefers more to cold, but not to heat, not to heat. And there's a palpitation, signs or excitability of the patient, presence of goiter, exophthalmos, tachycardia, or cardiac arrhythmia. Now, this is primary therapy. What is primary thyrotoxicosis? Primary thyrotoxicosis basically in which the goiter is diffuse and vascular. These are certain points in favor of primary thyrotoxicosis, and these points also differentiate the primary thyrotoxicosis from the secondary thyrotoxicosis. What are those? In primary thyrotoxicosis, goiter is diffuse and vascular, means goiter is diffusely enlarged. Whole of the thyroid gland is enlarged, and it is more vascular. Goiter may be large or small, firm or soft, and a thrill and a bruit may be present. Onset of the symptoms is abrupt, all of a sudden, because it's a severe disease, so the symptoms occurs abruptly. Remissions and exacerbations are present frequent, means sometimes the symptoms are aggravated and sometimes there becomes cessation of the symptoms. Symptoms are decreased. Hyperthyroidism more severe than in secondary thyroiditis. The signs and symptoms of hyperthyroidism means the features of toxicity are more severe than the secondary thyroiditis. Cardiac failure is rare in primary thyrotoxicosis but is more common in the secondary thyrotoxicosis. Other eye signs which are present in primary thyrotoxicosis in spite of the exophthalmos are the orbital proptosis, ophthalmoplegia, and peritibial myxedema are the other features of primary thyrotoxicosis. This is the secondary thyrotoxicosis. What is the difference between primary and secondary thyrotoxicosis? Goiter is nodular. Here the goiter is nodular, multinodular, while in case of primary thyrotoxicosis, goiter was diffusely enlarged. Onset in primary thyrotoxicosis was abrupt, while here the onset is insidious. In primary thyrotoxicosis, cardiac failure or cardiac features were not present, were very rare, but here the cardiac failure or atrial fibrillation are more common. Hyperthyroidism is not so severe. Here the signs and symptoms of hyperthyroidism, the toxicity of hyperthyroidism is not so severe as in cases of primary thyrotoxicosis. Then primary thyrotoxicosis, eye signs were more frequent or common, and here the eye signs are very rare. These are the differentiating points, differences between the primary and secondary thyrotoxicosis. How we can diagnose a thyrotoxicosis? The important primary and baseline investigation is the thyroid function test. What do we do in a thyroid function test? In thyroid function test, we get the serum level of T3, T4, and TSH. So these levels will be raised. Thyroid autoantibodies. Thyroid autoantibodies, which is the main feature of the Graves' disease, are which is the main feature of the Graves' disease. These are raised. What are those thyroid autoantibodies? Thyroid stimulating antibodies, which are of the anti-somal, anti-autosomal, anti-ribosomal antibodies. A thyroid isotope scan. This is a radioactive iodine thyroid scan. We use a radioactive iodine and then we get a thyroid scan. In thyroid scan, a radioactive iodine scanning, we found out, as we have discussed in the previous lecture of in the previous lecture of the thyroid goiter. Uh, Thyroid isotope scan will give us a picture of three type of nodules are appearing on the thyroid scan. One is the warm nodule, other is the hot nodule, third one is the cold nodule. The warm nodules, when appears on the scan, it means it's a normally functioning thyroid gland. Whenever there is a cold areas or cold nodule is appears, cold means non-functioning. Non-functioning nodule, that is a cold nodule. Hot nodule, when hot nodule appears on the thyroid scan, means it is hot nodule is the hyperfunctional nodule. It is overactive nodule. So in case of thyrotoxicosis on thyroid isotope scan, thyroid radioactive iodine scan, we find out the hot nodule. Either single hot nodule is present or multiple nodules are present, which are the hot, or whole of the gland is overactive. So this will differentiated by the thyroid isotope scan. So thyroid isotope scan will tell us either there is a single or solitary overactive area, we call it hot nodule, or there are the multiple areas or multiple nodules of the heart nodules, which will give us the clue about the hyperfunctioning of the thyroid nodule. So the thyroid isotope scan is a very important investigation in cases of a heart nodule, in cases of toxic nodule. Now, what are the treatment options? Treatment options in cases of thyrotoxicosis, first is the patient is very excited, patient is agitated, stimulated because of the sympathetic stimulation. So we advise the rest and sedation. We use the advise the patient to tranquilizers or sedative agents to keep them calm and quiet, to decrease their excitability and agitated behavior. Other is the anti-thyroid drugs are used initially, like carbimazole. It's the neomarcazole by the name of, in the market it is available is in the name of neomarcazole. So carbimazole is a very important anti-thyroid drugs. Initially 10 milligram 8 hourly is used for 2 to 4 weeks, initial dose. Later on, the thyrotoxicosis would be settled down up to a control level. Then we use a maintenance dose, 5 milligram 8 hourly. Beta blockers are used. There's the propranolol and NODULE. Propranolol, the enrol is used in a doses of 40 milligram BID or TDS. Because beta blocker, there will be the sympathetic stimulation, so beta blockers will control the sympathetic stimulation and the tachycardia, palpitation, and other agitated excitability that will all be controlled by the beta blockers. Other antithyroid drugs are propylthiouracil, para-aminosalicylic acid, and iodides. Iodides are also used as the antithyroid drugs. And second option, first of all, we have to start with the antithyroid drugs, means to control the toxicity of the toxic goiter. So first of all, we have to control the toxicity by antithyroid drugs, and these antithyroid drugs are used for a period of 1 to 2 years. And 1 to 2 years period is a maximum period to control the toxicity of the thyrotoxicosis. But if unfortunately the toxicity is not controlled, we may prolong the treatment, but these antithyroid drugs like the carbimazole has its own complications. It causes the agranulocytosis, it causes a sore throat, and certain other complications like aplastic anemia. So later on, when the thyroid toxicity is controlled by antithyroid drugs, then if the thyroid goiter is larger in size and it has got the same symptoms, then we have to advise for the surgery. In surgery, we usually use a thyroidectomy. Thyroidectomy is of different types, as I told you, the subtotal thyroidectomy, the near total thyroidectomy, and the total thyroidectomy. In cases of thyrotoxicosis, because the chances of recurrence are more, so we better advise for total thyroidectomy or near total thyroidectomy. If we will go for a total thyroidectomy, whole of the thyroid gland will be removed, then we have to keep the patient for a long life replacement on the thyroxine. The patient has to take the thyroxine tablet for whole life because there is no thyroid tissue, so no thyroid hormones are secreted by the patient. So we have to keep the patient on the long life anti-thyroid or thyroid hormone supplementation. This is the main problem with some of the patients which are living in the very remote areas and which have missed the follow-up most of the time. They are not attending their consultant or doctors. They are not regularly giving the follow-up to the thyroid clinic. That's why sometimes, most of the time, they miss the medication, thyroxine, so they will develop, comes to you with a severe type of hypothyroidism. So this is the main disadvantages of this total thyroidectomy. If the patient is a young one, if the patient is a literate, educated person living in the urban areas, it's better we have to go for the total thyroidectomy and advise the patient that your whole thyroid tissue is removed and you have to take the thyroxine supplementation for whole life regularly so that to avoid the hypothyroidism. So he can follow the treatment properly, but in case of those cases, the patients are belonging to rural areas and they are not educated too much, and we have a doubt that they may not maintain their thyroxine replacement for whole life. So the other option is a near total thyroidectomy, in which we remove the one lobe complete with isthmus, and only the 4 grams of the thyroid tissue will be left on one side. So that 4 grams of the thyroid tissue may secrete the thyroxine up to certain level that they can maintain the thyroid functions. But again, the chances of recurrence are there because the causative agent is present. If it is autoimmune, the autoimmune antibodies are present in the body. If it is any other cause is present, so there are the chances of recurrence. So if the recurrence occurs, then there is the redo surgery in the neck is very dangerous and difficult because the redo surgery may damage the recurrent nerve, may damage the parathyroids, and patient may develop certain more complications. And other is the radioactive iodine. Radioactive iodine ablation is another. Radioactive iodine has a role. We use the radioactive iodine for the thyroid tissue ablation. Now it depends what is the age of the patient. If it is more than above the 45 years, or females especially 45 years, and they have completed their family, so we can advise the radioactive iodine. But in the younger age group, the females who have not completed their family, the radioiodine is dangerous for their pregnancies. They may have the hazards. So that's why in young girls and young patients, we advise for the antithyroid drugs and controlling the thyroid toxicity by antithyroid drugs, and then we have to advise for the surgery. So in very old age patients, the radioactive iodine has the role, and the patients with a very small thyroid nodule, very small thyroid goiter. The patient which is a very small thyroid goiter, that patient maybe the signs and symptoms of toxicity or thyrotoxicosis may be controlled by antithyroid drugs. Then there is no need for surgery if the thyrotoxicosis is controlled by the medication. But if it is unable to control by the medications, it is controlled up to a certain extent, and when we stop, we have used antithyroid drugs for a period of more than 2 years. And in spite of that, when we stop the antithyroid drugs and there is again the recurrence of the signs and symptoms of thyrotoxicosis, then it's better that we should have to reduce the increased mass of thyroid tissue, which is secreting the more thyroid hormones, by surgery. Then there is the option of surgery is better. A patient is a young one, and we have controlled the thyrotoxicity up to a certain extent. In spite of that, after stoppage of the antithyroid drugs, there is a recurrence of the symptoms of thyrotoxicosis. So later, then it's better we have to go for the surgery and remove the maximum quantity of the thyroid tissue so that the secretion of the thyroid hormones from that overactive thyroid tissue is decreased. So this is all about the treatment of the thyrotoxicosis. Now, please, have you any queries, any questions regarding this topic? You can ask from me. Hello. I know.
Yes, sir.
G, yes.
Sir, I have a question.
Do you follow? Do you follow me?
Yes, sir.
हाँ समझ में आ गया any problem any query
Sir, I have a question.
Yes, please.
Why cardiac failure or atrial fibrillation occur in secondary thyrotoxicosis?
Yes, because in secondary thyrotoxicosis, there is the more sympathetic stimulation. That sympathetic stimulation will causes the more activation of the cardiac tissue, cardiac contractility increased. While in case of primary thyrotoxicosis, their sympathetic stimulation is not raised. The sympathetic system is not stimulated because it is an autoimmune disorder. It is because of the autoantibodies. So in which there is the increased secretion of the thyroid hormones. While in case of secondary thyrotoxicosis, there is the sympathetic stimulation. And you all know the sympathetic system will causes the tachycardia and palpitation, increased activity or activity of the cardiac muscle. That's why there is the more chances of cardiac failure because of the overactive cardiac.